Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This week we have Dr. Aebhric Gara, who is a cardiologist as well as specialist in pediatrics. Welcome back, Aedith.
Hello, welcome Aebhric, and welcome everyone listening for today's podcast. So the topic is again a pediatric topic, and we touch on fever of unknown origin. So this is a complex topic. This will be discussed today.
So this is something that remote medics don't get a lot of. We don't see a lot of pediatrics.
Yes, that's right. And so many pediatric cases in remote conditions, and also this topic, the fever of unknown origin, it's not so common in remote or even in general pre-hospital conditions. But I believe it's worthy to discuss and to see the background and to touch on some physical signs which can just raise some red flags when you have a pediatric case with fever.
So fever of unknown origin, FOUO, has many different definitions, and different people are saying things on what precisely that is. What, in your words, what is the definition of fever of unknown origin?
Yes, it's important to outline what is a definition, or how can we group, or how can we discuss FUO. And the European pediatric guidelines, they refer to fever of unknown origin as a fever which lasts more than 2 or 3 weeks. Fever is defined by degree of fever 38.3 in Celsius. And it's well documented, and the measurements are made in standard conditions. And also, it adds to the definition that there was already some diagnostic steps or some diagnostic tools, even in a hospitalization or in an ambulatory measure, and no one knows what is the reason behind. So when there's no pathology found by the basic diagnostic steps, I mean a general laboratory or general ultrasound, and there is still fever lasting for more than 2 or 3 weeks. So this is the complex definition, and as you just see, it's really not easy to deal with these cases, and it's really not easy to get to pathology and to treat it. I can also say that in pediatrics, it's a more benign condition than in adults, because in adults, when there's an FUO, I believe around 70% of the patients unfortunately dies before the diagnosis is made. So major, sometimes malignant conditions are behind an FUO in adults, and sometimes it's not easy to get to the root and to get the diagnosis. But it's not the case in pediatrics. So in pediatrics, after detailed and careful investigations, usually the reason of FUO is found, and after the treatment, mostly successful.
So you mentioned that 38.3 for more than 2 weeks. Up until that point, what are the carers doing? What are the moms doing that will treat this?
Yeah, so sometimes, or in many cases, the problem is that children with such high fever, they get to some medical treatment, or the parents themselves start to get some anti-fever drugs, and many times they also receive antibiotics, and without any proven infection, or without any cultures made. So sometimes it makes difficult to get the diagnosis when they are already on antibiotics. But sure, it's so fever is always a symptom. It's not the pathology itself, and it has to be treated to make the child in general feel better, but also sometimes the really early antibiotics makes the diagnosis harder.
So when they get antibiotics, how does that change their symptoms to make it more difficult for you?
When there's a true FUO, then it has to be proven that it also stays up without the antibiotics. So the antibiotics can mimic many accompanied symptoms. It can also influence the fever itself. So when you have to do the investigations, because it's a possibility of FUO, then the first step is to cut down every or any medications the children is receiving. Sure, if it's life-saving or if it's an anticonvulsant, then it has to be considered, but hardly cut down all the medications. So get the child completely medication-free and observe for at least 5 days and make standard measurements in standard conditions made by a medical person and not by the parent or the child themselves. So first, many FUOs are not FUOs that are first considered to be FUOs, because when the thorough investigation and the thorough observation is made, then it comes out that it's not a true FUO. And also parents need to be educated how to measure the temperature, what is fever, what is not fever. It's not easy because they are really worried about child with fever.
So you said the only way to really assess the pediatric patient is have them 5 days without antibiotics or other drugs. Does that include paracetamol or Tylenol?
So yes, the European and the Hungarian guidelines, which I'm familiar with, they tell that hospitalize the patients, to put them in, unfortunately, in hospital. It's not easy for a child, and cut all the medications they are receiving. Of course, if it's a life-saving one, or if it's a life-saving antiarrhythmics or life-saving anticonvulsant or whatever, then that can stay. But if it's possible and not life-saving, then cut all the medications and observe. And many times it turns out that it's not an FUO, or it turns out that it's medication-indicated FUO, because sometimes in children, even the antibiotics, anticonvulsants, also some antiarrhythmic drugs can cause fever. The first step is to cut all the medications.
Is that the same for adults as well?
For adults, so I would say that it's not that harshly written in the guidelines, and you can't cut completely an antihypertensive drug, because then there will be a roller coaster in the blood pressure of the patient. So no, it's not the same for adults. And also the drug-induced FUO is not frequent in adults. It's more frequent in pediatric cases. The reason is, or the complete reason is not really clear, but as we know that most of the medications are not tested in clinical trials in pediatrics, and also not tested on pregnant women, simply because they are not allowed, or simply they are not safe. So the most medications are tested in clinical trials on healthy and special patient groups, adults. And then when a medication is already on the market, then there's approved ways to report side effects, such as fever in pediatrics. But these reports are coming in rarely, or they are not so well documented. So as far as I know, drug-induced FUO is frequent in pediatrics.
That's interesting. So when you look at a normal fever in pediatric patients, don't the carers, the mom and the dad, don't they just whack in paracetamol right away?
For this, I would say that hopefully there's no parent who gives paracetamol for 2 weeks, or even for 10 days without seeing a doctor, So for this I would say that hopefully after a while they recognize that something is not right, or it's not just a simple sinusitis or a simple disease with some slight fever, and they will see a doctor, or they will cut the paracetamol and found out that the child is still ill and still has fever.
So how long do you give paracetamol before you decide you cut off the drugs and give them 5 days of no drugs so you can start assessing them?
So how long can you give the paracetamol?
Well, no. So somebody comes into you with a child, and they've been given them paracetamol, but they still have a temperature. When do you call? When do you stop giving paracetamol?
Yeah, I see what you you mean. So it's you can't leave the child having fever and kind of let them suffer. So what I would do, I would change the paracetamol for another anti-fever drug, and then see what happens. And if possible, then for a couple of hours, or I would say 24 hours, or I would cut the paracetamol or cut any other medications as well. And just it's important to see in pediatrics how high is the fever without any medications. So yeah, the guideline says that you should cut off all the medications and see what happens. When the child is already hospitalized, then in those conditions, it's easier to give IV drugs, or yeah, to get the child feverless in a more effective and quicker way.
Is there an other drug that you would suggest that a remote medic or a mom at home would give a pediatric patient with a fever before paracetamol, or is that what you suggest first?
If available, first I would choose ibuprofen. Yeah, like paracetamol and ibuprofen also has pros and cons. So both are really effective and safe in pediatric care as well. Ibuprofen also has some anti-inflammatory effect. Paracetamol is just a painkiller and a anti-fever drug. So considering this, the ibuprofen is a bit more effective because it also has an anti-inflammatory effect in pharmacokinetics. And then paracetamol, in high doses, it can harm the liver, and the ibuprofen can harm the gastrointestinal system and the gastric. It can, in long term, it can cause gastric ulcer. So those are the cons for both. Both are effective and available, and also they are prepared in rectal preparations, and you can give them in rectal if the child is not able to swallow, or it's not easy to give them. And both are available in syrups, so you can also give them to a child who is tend to swallow, and all are available in IV medications as well. Third one, which I recommend, is metamizole. That's also effective, and that's also available in all forms.
So we have a pediatric patient with a fever, and we take your advice and we give them ibuprofen and not paracetamol. And we do this for a few days, and they're not getting better. So we start taking them off the drugs for 5 days, and we're looking for a drop in fever. What other symptoms can we be looking for? What other assessment abilities can we use?
Besides fever, there could be many other symptoms and signs. We have to look for the really key ones, which are weight loss, blood in the stool, rash on the skin, and then also we have to investigate the joints, some swallowing in the joints, or some weakness in the muscles, or they just noticed recently that the child falls over more often than before. So these are some really red flags. These symptoms are so-called red flags. And then the others are depending on the side of the body where the reason of the FUO lies. I mean, it could be a chronic sinusitis. Then if you press, then the sinuses could be painful. It also could be a chronic otitis. If you press on the tragus before the ear, then that also can be a bit of painful. Sometimes the reason behind is an abscess. I can say that it could be mostly anywhere in the parenchymal organs, and they cause symptoms there. So it could be some slight abdominal pain, some slight pain in any joints.
So these are the red flags that we're looking for, the weight loss or red rash. Pressing on the sinuses in case of sinusitis, pressing on the tragus in case of earache. And if all of those are negative and no abdominal pain, what are you thinking? What's the next option?
So with the physical examination, I would say that I would really go from top to toe and pretty detailed. And I just mentioned here some other physical signs which can come. So you need to have a look at all the joints, all the tiny ones on the fingers as well. You have to look for and really thoroughly investigate any signs or any findings of an increased node on the neck or anywhere else in the axils or in the femoral region as well. Then you have to carefully listen for any murmurs from the heart. You have to carefully physically investigate the thyroid glands. Then you also, and for this, definitely needs comb conditions and comb ambulatory room or hospital room. But sometimes inflammatory bowel disease are the reason behind an FUO. And then you have to look for some fissures on the perianal region. So it's really a top to toe investigation with the physical investigations and look for any unusual finding or for any tiny pathology, because that could be the pathology of the FUO.
So the head-to-toe exam works for adults as well, because if you're in a tropical disease area or malaria area or anywhere where there's bites, that we need to rule out any of those pathologies.
Sure. That's right. That's right for adults as well. And as you just mentioned, the malaria, one of the major groups of the conditions behind an FUO is some infection. And those are not the common infections. Those are mostly some complicated or rare ones. For example, from the viruses, could be a C hepatitis, or it could be an Epstein-Barr virus, which is more common, but in some people it causes FUO, or in some pediatric patients. We can also mention that bacterial infections can cause FUO. For example, the Mycoplasma or Salmonella as well can cause, and Salmonella is unfortunately kind of frequent in pediatric places like the kindergarten. Sometimes it comes up, and then of course some fungal infections as well. And you have to think about the protozoans, as you just mentioned, the malaria. Those who are for any reason already immune suppressed, maybe after a renal transplant or an autoimmune pediatric patient and taking immune supplement medications, then in those cases you really have to count with infection.
You mentioned that we could use rapid diagnostic testing to assess for, including blood in the stool dysentery, or we could do a EPOC CBC chemistry panel, or there's a lot of these things you can rule out. Is that what you're seeing here in Europe?
Sure. So for the laboratory exams, the list is really, really long. So with the point of care test, you can rule out some of these infections which I mentioned, and also you can use the blood in stool test. I would repeat that for at least 3 days to see that that's truly negative, if that was negative for the first investigation. And then the list of laboratory exams which they can perform in the hospital is just kind of never ending if it's a true FUO, and if you really want to, and you want to dig deep into the pathology, because then you can do all the autoimmune panels, you can do all the serology exams to find out any previous or ongoing infection. You can do repeated blood cultures repeated urine tests, repeated stool tests. So it's from the side of the laboratory exams, it's really really long, and when some result comes back, then that can trigger another one. But if it's a true FVO, then the children have to go down all the laboratory exams.
Are you finding them hypoglycemic? Is a prolonged fever of unknown origin going to drop their sugar stores?
Yeah, it can. I wouldn't suggest that that's a leading symptom, but just by the physiology, fever decreases the blood sugar level, but it's not compulsory to have hypoglycemia. But yes, you definitely you have to measure, and if the child is hypoglycemic, you have to treat. But that's not a leading symptom.
I was preparing for this talk with you. I was looking through PubMed and looking to see what fever of unknown origins were there for the returning traveler. And a lot of hospitals and GPs are not testing for these exotic diseases because they're not asking for recent travel. Is that something that you've gotten in the habit of doing?
So I believe that asking for recent travel and really thoroughly getting the history is one of the most important tasks when we investigate an FUO. So I'm surprised that some GPs they are not dealing with this.
So we've talked about the definition and symptoms and a bit about the treatment. What's the pathophysiology behind this? Why is this happening?
As I mentioned, one big group is the infection, and another is the autoimmune diseases. Then the third big group is tumors and malignant diseases, and the fourth big is the drugs, which we just discussed in the beginning. And then there's a fifth, which is just like some others, some really rare and really special diseases. So in general, the pathophysiology, or the key, is still under investigations, and it's in the focus of clinical research and translational research as well. So somehow the fever centrum in the central nervous system is triggered, which is a normal reaction of the body in response to a harmful agent, which can be a harmful infective agent, a bacteria, or it can be a harmful agent as a medication, as a foreign agent in the body. And in some patients, this response is overrated and lasts for a long time. It's even interesting to consider why do we define FUO as we do. So why do we say that 2 weeks? What if some patients or some children, for them, the normal rate of the fever and the normal slope of the fever lasts that long? And it might be that it's not a pathology. So it's really important to observe for a couple of days and to take the history as deeply and as thoroughly as possible, and also make individual decisions and tailor also the investigation and also the treatment tailor for that patient, because it might be that it's not pathologic at all, or it might be that it's just a longer fever than usual. But we have to take the symptoms seriously, because sometimes that's the only symptom of a malignant tumor in a child. So I would say that, again, to tailor and to make individual decisions.
So there are some literature discussions about intermittent fever, so daily fever every 2 days, every 4 days. Is that something that you see here in Europe?
So I would like to say here that two things are on my mind. One is the circadian rhythm, that we have daylight, we have night. Sometimes we sleep, sometimes we not, because we have a crying baby, or we have a night shift, or we have a jet lag, and that can interfere with our circadian rhythm, and that can also interfere with our temperature. And it could be that after jet lag, you are subfebrile or have a fever. Some people have this, and the other one, it's also kind of cyclic thing is the menstruation cycle for women, which by its origin the hormone levels are changing week by week, and that can also and it's well documented, so it's well known from physiology that it can really influence the temperature. So yes, I would say that we don't really know how many things, and nowadays in our rushing life, how many other things like just stress or the news or whatever influences our temperature and the hormones, and it can be that there's a 2-day fever and no major pathology behind.
That makes sense. I am reminded of some of the fevers that we saw in the Kilimanjaro Christian Medical Center and pediatrics coming in with fever from malaria and basically the Vivax. And it's just common. They say, well, yeah, every 4 or 5 months, I have fever for a week. And after a week, they're fine. They just kind of stabilize.
Yeah, that's interesting. And also sickle cell disease and some hemolytic periods happening in that condition, that can definitely cause some fever for a couple of days without any other major symptoms or any other problems.
Well, Dr. Gara, this has been interesting. If you could boil down pearls of wisdom for the pediatric fever, what advice would you give to the remote medic, austere medic working out there?
I believe that the diagnosis of FUO is it reaches over remote conditions. So first thing first, we don't let any patient suffer. So give the anti-fever medications. My other major advice is to, as much as possible, even in remote conditions, do the top-to-toe physical investigation for very, very thoroughly, and look for any minor signs, because that can be game changer in the further investigations and to get to the diagnosis. Use your available point of care tests, quick tests, because that can also, if you have a positive one, or even if you rule out many conditions with those are extremely informative, and it's easier after in the hospital to complete the investigations. So these are my major messages from today's discussion.
That's brilliant. I appreciate that. So that's it for this edition. Thank you for your time, and we'll see you again next month.
Always a pleasure.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, Corum, corum.org.